Never You make sure at least one of those gets to bed, right?
Yeah, just keep an eye on it. Actually, safety on that.
That's smart.
But I would jump on it, I would move my bed and make sure that the floor still and then snap off, like
the legs go out.
yeah, I was raised up.
Yeah, so.
And I like how it's like lower. So like those
I hate when they call it eating now.
Okay, so I finally got to grading the second homework set, and the class average was 9.9 out of 10. So wasn't too many problems there. I'll post the grades on Canvas after class, and you can pick it up after that if you'd like. Yeah?
Since we all did not do so well on the quiz, is that possible we can add a bonus in there?
People don't seem to do all that well on my bonus questions, so I can put another I can put a bonus question on. But
That'd be great, yeah.
Okay. And so now that I did the second homework, now I'll be able to release the third homework. So I don't get behind on grading those. So, as I mentioned, there were a few things from some prior classes that I wanted to go over before having the next quiz. And one of them was just this last little case that was at the very end of last week's acid base, because I kind of ran out of time and just blew through it. But just as an example of the type of situation where one might have an acid-base balance problem, and again, the steps to use to kind of identify if there's a problem, if there is, what kind, is it a respiratory or a metabolic kind of disorder, and whether the extent of compensation and things of that sort. So anyway, here we have a person who has been on international travel, which is always a good thing to put in there because you can pick up all sorts of things internationally or whatever. And but has severe diarrhea amongst other things, and these blood values in terms of what would be of note with regard to acid-base balance. And so remember, the first thing is to take a look at the pH, just to see, obviously, if it's greater or less than 7.35 to 7.45, and in this case, it's less than 7.35, so it's an acidotic situation. And then you look at the two factors that are important for the bicarbonate buffering system, which is the primary buffering system, and that's PaCO2 and bicarb. And is the is the PaCO2 within the normal range? And in this case, it is. It's a little bit at the lower end, but about but 35 millimeters of mercury would be considered within the normal. but bicarbonate is significantly lower. Okay, so this would suggest that it's the bicarbonate pool that is the problem, and so that's metabolic. So we have an acidotic situation. It appears to be metabolic. So the next thing is there an anion gap? Okay, because is this metabolic condition associated with something like diabetes, or is it something associated with loss of fluid or loss of protons and the like? So if you, for the anion gap, remember that's the sodium minus the combination of chloride and bicarbonate. So in this case, it's 110 plus 18, so it's 128. 138 minus 128 would be 10. And that's within the range of what the anion gap tends to be. So it's not because we have some increased levels of lactate or some other kind of acid. And so we'll just basically leave it at that. I mean, you can go on to other considerations with it. But this would be considered a non-ion gap metabolic acidosis. Okay, yeah.
If there was a situation where we account for albumin, what kind of values would we get?
So
Would they be like a blood test for albumin?
so you'd certainly have to have the albumin level. I mean, that would be given to you, or there would be a situation where you would expect some kind of most likely liver injury or a problem with the liver. And with regard to some of the other, liver enzymes and things of that sort. So you get a better picture of what's going on with regard to the liver and the albumin production being just one of those. So just wanted to kind of go through that maybe a little bit slower. Any questions about kind of doing that kind of analysis? It's pretty straightforward. You do get into, as you'll see in other classes and therapeutics and the like, that it can get a little bit more complex when we're talking about compensation, the degree of compensation and things of that sort. But
Can you repeat that, what the diagnosis was that you said?
a non-ion gap metabolic acidosis. Mm-hmm. Okay, so coming back here, we still had some things to finish off, and so that was the second homework assignment, and I apologize for the lack of the zero. So that seems to be a major issue for me. One thing that I just wanted to make note of, because only a couple people picked up on it. Okay, so the sclera was red but not ecteric. Okay, so numerous people said, well, if you had significant liver injury, then you get icterus, you get ecteric sclera. But the redness is actually helping you confirm it's just one of a contextual thing of alcohol. Because alcohol, particularly acute alcohol, will cause vasodilation in the small capillaries. And so the redness is because of alcohol producing this dilation. And so that was a clue in context for alcoholism. Not to say that there weren't other things in there that would say that, and including to the fact that it says it's an alcoholic. But that redness is, and again, it's just to start looking at these things and picking out the things that are important in terms of either confirming or maybe coming up with some alternative ideas as to exactly what was going on. So going on to the last 4 or 5 points. Well, yeah.
In regards to if we have reading case again, do you want us to be doing our own research in addition to what's on the slides, or do you want us to just use what is on the slides?
So what most people did, which I think was appropriate, was to use this and really place it into context, okay? If there was some aspects that you thought needed to have some support for saying X, Y, or Z, that certainly is appropriate to put in there. I would, hope to see that, but it doesn't require extensive resource development or whatever. So in terms of, again, we're talking about the cellular components of blood analysis. The differential count, generally is provided along with a total white blood cell count so that you get an idea about the relative distribution of the different cell populations and whether or not there's one in particular, say, if there's an increase in white blood cell count overall, is it because of neutrophils? Is it like a big expansion of the lymphocyte population? And that'll give you some information as to whether or not, for example, the person has an infection or possibly some kind of bone marrow condition like a leukemia or peripheral lymphoma. So in general, these are, pretty broad percentage ranges, but neutrophils are always the largest population in an individual that is not experiencing some kind of infection or some other kind of condition of that sort, with about half the cells, maybe a little bit more of the cells, being the neutrophils. We'll talk about band neutrophils in just a minute, but they represent about less than 10% of the total neutrophil population. Lymphocytes, 20 to 40%, monocytes, 2 to 8%. Anecdotally, a person whose monocytes are at the low end, 2-3%, something like that, tend to be more prone to infections, particularly viral infections. Conversely, those at the upper ends, 8%, something like that, they rarely seem to get the flu. They rarely seem to get colds, things of that sort. Just that small difference in monocyte macrophage population seems to be something that impacts the ability of the innate system to control these viruses. Yeah.
Is there a way to boost the production supplementally or anything?
Nope. It's basically, it appears to be just what you were born with. Yep. Eosinophils, 0 to 4%. On the high side, you might see with people that have certain types of allergies, but for the most part, pretty low. Same thing with basophils, even lower, 0 to 1%, something of that sort. So characteristically, they look quite different from each other. And so the largest of the group are the monocytes with a large nucleus. Lymphocytes, smaller, again, Most of these are lymphocytes that are so-called small lymphocytes. They are just trafficking between different tissues within the immune system, and so they have not transformed into, for example, B cells or even T cell populations that are active are not noticeably different in terms of size, shape, and the like. That's why we have to use surface markers to distinguish the different lymphocyte populations. Eosin and basophils have lots of granules in them. They're fairly large. They have more kind of lobulated nuclei, certainly not like a neutrophil, but a little bit more, almost like a band cell, as we'll see. And then neutrophils with these polymorphonuclear contents, and so quite characteristic of those. So you'll hear left shift in respect to a differential count. And this gives you an idea about the magnitude and to an extent the duration of an infection. So essentially these cells, as they start out originating from the, during the maturation process in the bone marrow, they go through a series of stages where they become more and more differentiated, and at the same time their nucleus becomes more and more lobulated. And this guy in here, right buddy, would be a classic band cell. So, from that chart, about 3 to 5% or so of the neutrophils are band cells. That's what we're talking about, is a cell that has a nucleus that looks like that. And these cells are immature. They normally are not being released from the bone marrow because they still need to go through additional maturation stages. But when you have a major infection and you're releasing mediators to recruit neutrophils, those mediators can access the bone marrow and start to release these immature neutrophils, and the number of band cells will increase significantly. So a neutrophil left shift essentially is this appearance of more immature cells within the blood in response to an infection. And the degree to which we see these immature cells is the magnitude of the left shift. And for the most part, you'll see a moderate, mild, moderate left shift with an infection that is transient, that is going to be controlled for the most part. Severe left shifts are for really life-threatening types of infections where the bone marrow is just dumping these cells because there's so many mediators that are triggering the release that you get these not only band cells but even more immature cells. So the other aspect to infection and the source of the neutrophils is the release of neutrophils from the capillary endothelium. So under normal circumstances, as we get neutrophils being released from the bone marrow, they will circulate to an extent, but then they marginate. They basically stick to small capillaries. And so what's truly circulating is a fraction of the number of neutrophils that are in the circulation, or at least available. When you get again, an infection, it's the production of mediators to not only increase production of bone marrow, it also increases release from the endothelium. And so you can get a very initial, very rapid rise in neutrophils coming from the capillary epithelium. That by itself is independent of left shift. I mean, it'll be this an increase in neutrophils that are all mature neutrophils. So we get that, plus we get this left shift phenomenon. So eosinophils, we'll see these primarily in mucosal membranes, the intestinal mucosa, the lung mucosa, and these guys, relatively small in number, but they do seem to protect against parasitic infections, as well as yeast and some bacterial infections. With regard to the bacteria, they're probably not a major determining cell type with regard to whether or not you're able to fight off an infection, but particularly with regard to yeast and parasites, they're fairly significant. We'll also see eosinophils come up in response to allergic reactions. So with the production of cytokines, as the development of the allergic reaction occurs and the production of IgE, we get production of certain interleukins that expands the population of eosinophils. And particularly in the lungs, we'll see this in eosinophilia, and that's associated with allergies, particularly pollens and other allergens of that type with regard to the lungs. So eosinophils, not a large population that circulate, but have some significant impact in tissues where they are located. So that was to finish off the cell components before getting into the soluble components. And a question, yes?
So in terms of the left shift, those immature cells that are being released.
Yeah.
So are they functional? Is there any like significance to them other than you can find, like you can understand that there's an infection going on?
So they're, depending on how far left shifted they have various levels of functionality. So all the way to the right, you have a fully functional cell that can produce lots of reactive oxygen species and can phagocytize. As we're going backwards, band cells, they have fewer granules, so they have less immediate ability to kill things. And when you go even to the left of the band, then they're basically just egg cell. They don't have too much in the way of a function at that point.
But they're never actually harmful to yourself. Like,
They're never what?
They can never be like harmful to you? Or like,
No.
Okay.
Anything else? Okay, so. running out of time already. So the picture, there is a significance, which I'll get to at the end if I have time. This particular painting by Lillywhite is an example of the Taos school of painting, which was developed, or a movement of painters in the about 1920s and on, painting in Taos, New Mexico. And so these are Western painters. Lillywhite is one of these very well-known individuals in this painting style, and which are basically big, generally big landscapes, lots of Western characters, things of that sort. Not a lot of detailed, but realism in terms of the content. A fairly, some of them are almost impressionistic in terms of their style. And the significance here is the cows. But like I said, we'll get to that if we have time. So coagulation is the other major component of blood that is clinically analyzed, not only for diagnostic purposes, but also for therapeutic monitoring purposes. Since the use of anticoagulants in a number of different clinical conditions is very prominent. So these slides, hopefully you recall, they are the same slides talking about the initiation of clotting when we have, in this case, an area, some damage to the endothelium, and with it, the activation and localization of platelets to that site. And the with the activation of the cells, we place on the surface of the outer membrane factor V in its active state, along with calcium in the phospholipid environment, where we're going to then activate thrombin and with it, the production of the fibrin clot from fibrinogen. So just a very quick reminder that this is where we're working on platelets. And so the platelet component is integrally related to blood coagulation. So whenever we talk about coagulation, we always have to consider platelet levels, for example, if platelet levels have fallen. And but today we're primarily focusing on the soluble components of platelets we talked about in the prior class. So again, just this, not only the dramatic change in platelets where all the action is happening, but here these fibers are forming that initial clot that's going to aggregate or help form this mass of platelets to plug up this particular vessel, and ultimately those fibrin molecules are going to cross-link and develop a very stable extracellular matrix around the platelets. So our fibrin cascade again, this portion down here, the final common pathway, is what's happening on the platelets and within the platelets. Within the fibrin clot with regard to ultimately 13A, producing those crosslinks, the transglutaminase, being able to introduce those crosslinks into the fibrin molecules. And we have the two different pathways, the extrinsic pathway, the intrinsic pathway. through which we can activate the final common pathway. And the extrinsic pathway simply means that it is some kind of traumatic injury that is able to release this molecule called tissue factor from the subendothelial space, and with it, the activation of factor 10 to 10A. In contrast to the intrinsic pathway, where we have something that happens physiologically, or at least within the system, that exposes a surface that will now activate the initial stages of coagulation by formation of kallikrein. And this is more of a biophysical interaction with a charge on the surface that's able to alter the binding and formation of active kallikrein and the initiation of clotting through a series of these clotting factors that are normally circulating. Yes?
Can you give an example of the two, both pathways?
In what way? You mean
Like what kind of
injury or something like that?
would happen?
So extrinsic pathway, chopping off your hand. I'll do it. Anything of that sort, okay? Intrinsic is like you, for some reason, there's an apoptotic trigger and some endothelial cells die. And so for that very small the blood vessel, there's now a subendothelial membrane that this blood is looking at instead of the non-thrombogenic endothelium. Another situation is, say, when you have, say an artificial valve or something implanted into the heart, where it is relatively non-thrombogenic, so it doesn't really activate the extrinsic pathway, but seems to promote, at least in time, some activation of the intrinsic pathway. So it's a more subtle kind of injury, or not injury, I don't want to say, a change in the endothelium that triggers the intrinsic pathway compared to the extrinsic. Okay? So these tests that are done can help to identify deficiencies in coagulation factors. The most prominent of those, the hemophilias that result in an inability or very delayed ability to coagulate the blood, as well as use for, as I mentioned, anticoagulation therapy. So you'll see things like PTs, INRs, APTTs, ACTs to an extent, but not quite as much, used for determining exactly how much anticoagulant a person needs to be administered and whether or not they have been over anticoagulated, something of that sort. In terms of the tests themselves, there are some, very technical issues that can vary the absolute numbers. And so there is a range, as with many of these clinical tests, and part of it has to do with whether or not in getting the blood sample that you're going to use, was there something done that promoted the initiation, maybe not a lot, maybe not extensive, but some activation of the coagulation pathway already. So that when you measure it, you're already in a state for that sample, which is a little bit more procoagulant than it would have been otherwise. So using like a small bore needle, because then the blood is going to have more interaction with a metal surface. Sometimes phlebotomists have a problem getting a decent stick, and so there's significant endothelial trauma. So all these things, anything that relates to the sample collection and its possible change in the blood sample, that could make it a little bit more coagulant. So prothrombin times used probably of the coagulation tests, it's about the most common one. 10 to 13 seconds is what you'll tend to see for a reference range. These are very much lab specific because of how we start the process. So remember, so in this case, what we're going to do is use the extrinsic pathway to coagulate the factors, okay? So that initial event is the release of tissue factor, right? So the actual preparation that's used is called thromboplastin. And up until recently, it was obtained from different tissue sources. It was primarily obtained from placentas, and from batch to batch to batch, you would have slightly different levels in your final preparation because it was never purified to 100%. It was always somewhat of a mixture of components to it. Now there's a recombinant tissue factor that's available, and that makes it certainly a lot more reproducible, but it's a lot more expensive. So there's still a lot of PT times that are done using the tissue factor extracted from placentas. Yes?
The tissue factor is factor, so that's part of the extrinsic pathway?
Right, so it's that.
So
that
you induce kind of intrinsic pathway.
Right.
By using nothing.
Yep. And there was some kind of a brain mishap when I did this. So notice that I think I had enciterated whole blood in your slide set. It's actually citrated blood plasma, okay? It's not whole blood. So just be sure that that's corrected in yours. So given that the activator for this pathway was not a pure protein or pure reagent, then years ago, people came up with this INR concept. So it's the International Normalization Ratio. And this concept of basically comparing a value to a known standard is widely used. And in this case, what you did is for an individual laboratory, they would take their patient pro-time and divide it by the mean pro-time that had been determined in that laboratory for individuals that had no known blood problems. And from that ratio, you then convert it to an INR using the International Sensitivity Index, which is the reference value that the tissue factor, the thromboplastin, was referred back to. So World Health Organization had a standardized preparation of thromboplastin, tissue factor, and a manufacturer would, make up a batch of thromboplastin, and they would essentially calibrate their new batch against this known standard. And the difference between the activity of their new batch to the World Health Organization standard is corrected for by the ISI. Okay? So the idea here is that what you're trying to do is convert these values back to a known standard. And in this case, it's this World Health Organization standard. So that even though Lab 1 and Lab 2 come out with slightly different protimes, the INR value would be the same for each. Okay? And so INR values you'll see used particularly for therapeutic monitoring of anticoagulants. And agents like warfarin, which internationally is still the most widely used anticoagulant, is dosed based on INR values. And so you would basically treat a person for several days. If they had conditions that were pro-thrombotic, such as deep vein thromboses, or they had atrial fibrillation, which has a tendency to throw off blood clots. And you would reduce the INR or the clotting to about 2 to 3. So under normal circumstances, and again, this is kind of the way that the values were set to. The normal INR is about 1. Pretty convenient. So by reducing the INR to, well, it sounds weird, increasing the INR to 2, you're basically reducing the propensity of that person's blood to clot. For many situations, we want to keep the INR about 2 to 3. If it starts to exceed 4, that generally indicates the person is over coagulated. The potential there for hemorrhagic strokes go up, as well as spontaneous bleeding in other compartments too. So one of the problems with too high an INR. Now, activated partial thromboplastin time, or APTT, is measuring the intrinsic pathway. Okay, so we're starting at the top there, where there's some change in the endothelium which promotes activation of kallikrein and the initiation of the intrinsic pathway. And for reasons that we really don't need to go into at this point, there's certain types of anticoagulants that are monitored by APTT instead of PT, okay? And the two most common ones, well, the most common one is heparin therapy. And the more recently introduced, the direct thrombin inhibitors, dabigatran being one of the most popular ones. And because of how they work, it's better to use the intrinsic pathway. Clearly, if a person, has a bleeding problem not associated with being anticoagulant, but just because they have some kind of deficiency in a coagulation, we can use this pathway to, again, diagnose a person, or at least help to diagnose a person with an intrinsic pathway clotting deficiency, okay? So that was, to an extent, the reason for having, these two different activation schemes, because that way you could look at a problem in either the extrinsic or the intrinsic pathways. But as it turns out, they're used more for therapeutic drug monitoring than they are for that, just because of the number of people that have coagulation problems. Activated clotting times, as you can see, they are much longer. And these are used primarily, and one of the most common places is in the operating room, when a person is undergoing some kind of say, bypass surgery. So the person has to be put onto a bypass pump, and you really jack the anticoagulants in those individuals because of the potential for clotting as the blood goes through the bypass pumps. We use factor 12 on whole blood, and again, it's just for those situations where you have very high levels of anticoagulant on board, and the other tests would be more problematic. So a question, after I unlock it, is the reagent used to initiating clotting for protimes. Silica for APTT, platelets, never. Factor 5, never. Okay. In terms of a clinical assay, thromboplastin, extrinsic pathway. Okay, now those tests are for the propensity of the blood to coagulate. There are also times when we want to determine whether or not there is clotting going on, and that's what's causing a clinical condition. And so there are a couple of measures. There's fibrin degradation products and D-dimers, and they're both associated with fibrin, but there are some differences in terms of what is being measured. So, oops, I forgot. So reference range is less than 10 micrograms per mil. And the idea is that when you are actively coagulating in the body, in the blood, we're also activating the fibrinolytic system, if you recall, and that's plasmin. So with clotting, you get breakdown of fibrin, almost not, obviously not to the same degree, but it does get activated about at the same time. So we'll start to see in the circulation breakdown products of fibrin, but also fibrinogen. So plasmin can also chew on fibrinogen. And so we look for the presence of these breakdown products in the circulation when it's suspected that a person has some kind of intravascular coagulation going on. One of the most severe forms of that is disseminated intravascular coagulation, meaning that there's clotting going on and it's occurring in multiple organs, multiple locations, and it can be certainly life-threatening. We can also use it as a quasi measure of thrombolytic agent activity. So when you have certain types of clotting events going on, like in a stroke or in a myocardial infarction, we can introduce fibrinolytic enzymes that'll start to break down those clots, and the release of these products will be a measure of the activity or the function of it. The other thing is that there is certainly false positives in menstruating women because of the uterine clotting that is required at that time too. So it's not absolutely specific for some type of extensive or pathologic type of clotting.
So DIC is basically there's so much of coagulation in the body that all the clotting factors have been used up.
Not that they've been used up. I mean, you start to use them up. But the problem is that you start to form blood clots in perfusing vasculature throughout the body. And so obviously you have ischemia being produced, but you will start to use up the clotting factors with time. So in advanced case of DIC, you'll see actually an enhanced bleeding possibility because they've used up all their clotting factors. D-dimers is more specific to a clot that has been broken up because the D-dimer is formed from two fibrin molecules that have been chopped up by plasmid, and that cross-link holds these two pieces together. And so that's the dimeric nature of this. So it's specific to fibrin breakdown and used for, again, looking at particularly thromboembolytic events that might be going on in the individual. And we'll either take the mini case up next time or do something with it, but we're out of time again. And I didn't get to my cow story. But anyway, any other questions? No? Okay, we'll see you next week.
And this new information will be on the quiz.
Yes.
So those four. Will you be putting any sort of mini case on an exam or anything, and thus have to decipher kind of what is going on? Or is that
I wouldn't put that onto a quiz.